My name is Lorraine Lipscomb, and I'm the Director of the Novo Nordisk Network for Healthy Populations. So welcome, everyone, and thank you for attending today's seminar entitled Precision of Diabetes is Now Becoming a Reality in India, presented by Dr. Viswanath Mohan. Before we introduce you to Dr. Mohan, I'd just like to quickly review some housekeeping items as we have many people online. I see there's something in the chat.
Just want to click that. I was just checking to see if people could hear.
Oh, okay.
If you just want to click that.
Okay, great. Okay, sorry. So first of all, we appreciate our audience muting themselves during today's presentation. There will be an opportunity for questions at the end of the session, and we will be inviting questions both through the chat box or by using the raise hand function for those online. If you have questions during the event that you would like the speaker to address at the end of the session, please enter them into the chat box and we'll do our best to get to as many questions as we can. And of course, the session today is hybrid, so we have some people live in the audience as well. Lastly, please note that today's session is being recorded, and we will make the recording available on our website if you'd like to go back to it or share it with others who couldn't make it today. Now, I'd like to pass the mic on to our inaugural chair of Equity in Diabetes Health Care. Something, I'm sorry, I didn't write it here. Dr. Beju Shah, who is my co-host for this talk today. And I'll pass it on to Dr. Shah just to introduce our speaker. Thank you.
Thanks very much, Lorraine. And it is my great pleasure to introduce our speaker for today, Dr. Viswanath Mohan. Dr. Mohan is the chairman of the Dr. Mohan's Diabetes Specialty Center in Chennai in India, which is an IDF center of excellence for diabetes care. He oversees a chain of 50 diabetes centers across, well, actually, no, more than that now, right? More than 50 diabetes centers across a large swath of India, and has over 600,000 registered patients in his electronic records. He's also the chairman of the Madras Diabetes Research Foundation, which is a center for advanced research in diabetes and is Asia's largest standalone diabetes research center. And his main research interests are in epidemiology of diabetes and its complications, the genomics of diabetes, including monogenic diabetes, which we'll be hearing about today, precision diabetes, and nutrition in diabetes. He's very interested in research ever since his undergraduate medical student days, and he has over 1,600 papers in peer-reviewed publications and nearly 200,000 citations. He's received multiple awards, including the Harold Rifkin Award from the American Diabetes Association and an FRS from the Royal Society of Edinburgh. And importantly, the Padma Shri, which is one of the highest civilian honors available from the government of India. So it is my great pleasure to welcome my colleague and friend, Dr. Viswanath Mohan.
Thank you both to Dr. Lipscomb and to Dr. Shah, whom I've known now for quite some years, and good friends of mine, and hopefully we will be able to collaborate quite soon in many areas of common interest. This is my first visit to the Novo Nordisk Network for Healthy Populations, and I must say I'm very impressed, not only by the buildings and the work that you do, but also the beautiful scenery, the kind of almost like a forest it looks like that you're inside. So you're very lucky to be in such a beautiful campus. Thank you for having me over, and hopefully if we have collaborations, I'll be able to come more often. So the topic has already been introduced, and the hospital, the main hospital that we have is shown on probably on your left, and on the right side is our research center, which is in the outskirts of Chennai. I have no conflict of interest to declare. The funding comes from government sources, Indian government sources, and also partly from the NIHR, the National Institute of Health Research in the UK. So this is the question whenever we talk about precision diabetes or personalized diabetes. So we know that in life there is no one size fits all. And yet when we talk about medicine, we talk about diseases, we try to compress everything and treat all individuals as if they were the same. Obviously, you can't give the same shirt or the same tie to anyone at any age. So then how can the same treatment be given to everyone with diabetes? So the terms precision diabetes and personalized diabetes are defined differently by different people. And I'm just coming from a meeting, 2-3 day meeting that we had at Vancouver, the Keystone Symposium, which is exclusively on precision diabetes. I'm very privileged to be part of that group, of that working group, and to represent India on that for last few years. And a lot of work has happened, and the Keystone meeting at Vancouver was to decide what to do next and to take precision diabetes to the next level. So to make a distinction between these two, this is my own little definition that, and I was very happy when at Keystone, they brought up a similar kind of a graph showing this, and this is a slide I've been using for many years now. So precision medicine, or precision in this case, diabetes, it's a narrower concept. So you try to do science, whether it's clinical trials, whether it's genomics, proteomics, biochemistry, clinical parameters, whatever you do. And I'll show you that you really don't need genomics and so on in every case. Response to therapy can also change based on ethnic groups. And based on all that, then you can feed in things into a computer, and the computer now tells you the moment you feed in. In fact, we have such programs running at our center because we have these 50 centers and we have to make treatment uniform. We already have these programs running at our center. So the computer can then tell you that for this given person whom you're treating, this particular treatment seems to be the best. But then you tell this to the individual sitting in front of you, and he or she refuses it. And says, I don't like this. I hate this drug. Tried it before, don't give it to me. So where does your precision medicine go then? So you have to personalize it. In our country, so that's a social context, patients' preferences. There's also a cost factor. Now, suppose the computer tells me that the GLP-1 receptor analog is the best, and the patient can't even afford a metformin. Then there's a question of, in my country, unlike yours, where everything is given free in your country, not, I presume that in India, but certainly in my country, 70% of people pay out of pocket, which means everything, the consultation fees, the tests, the medicines, everything they have to pay out of pocket. So if you prescribe GLP-1 receptor analog to a carpenter or to a driver or somebody, he's not going to take it. There's no point even prescribing it to him. So there goes your precision medicine. So you have to personalize it at the end of the day. Now, this was the time when the precision medicine in diabetes initiative, or PMDI as we call it for short, was actually started in 2020. This actually, the whole of precision medicine came from Bill Clinton's initiative. He started giving money for precision medicine, and then slowly diabetes field took it up. And in 2020, the first group of people started studying precision medicine with John Nolan and many others involved, Louis Phillipson, Stephen Rich. And so different people came in who had interests in type 1 diabetes, type 2 diabetes, gestational diabetes, and monogenic diabetes. These are the 4 areas. But then within 2 years, they realized that there was something amiss there, because 2 of the countries which have 40% of the whole world's diabetes were not included, India and China. So they included Linong Ji, my good friend from China, and myself. And ever since then, we have been working very, very hard. Almost every week we have Zoom meetings to discuss this. And from it, in fact, we organized as part of an organizing committee, which organized a meeting on precision medicine, online meeting somewhere in 21, 22. And from there, we took off, and we realized that precision medicine itself is too big. So precision diabetes itself is too big for anyone to study. It's just, so we had to split it into different groups. And I'll show you what we did. But as a result of this, 168 scientists all over the world worked together on different aspects of precision medicine. And then this was the culmination of a master paper, which we called as a second international consensus report on precision medicine, published in Nature Medicine. This was actually published on October 5th during the EASD meeting in Hamburg. And while that presentation was going on, Paul Franks and others were presenting it, we were all there. 18 papers got published at the same time. So, and few more are coming. Subsequently, another 2 or 3, I would say 20 papers, of which the first one, this one, was a master paper where everybody was involved. And this is a kind of an overview of the entire precision diabetes. And then each one of us split into different groups. And for example, we had precision type 1, precision type 2, precision GDM, precision monogenic. And in each of these, type 1, there would be precision type 1 diagnosis, type 1 prevention, type 1 treatment, type 1 prognosis, type 1 monitoring. And similarly, for type 2, GDM, and so on. So that's a number of people who are each one, 10, 12 people working on a particular problem. So I was allotted to the type 2 diabetes prevention project, and I quickly realized that this is going to take a lot of my time. So I brought in one of my junior colleagues, Bodhini, who joined, and then she did most of the work in that, and she was rightfully made as the first author of that paper. And so that's a paper where on precision diabetes. And this is all in communication medicine. So we had 17 papers at the same time published on all these different aspects. And some, like GDM, were not fully completed. So now, last week, we had few more. Then we wrote one more in the Lancet, which I think I'll be referring to, asking the question, is it even relevant to low and middle income countries? And it's not even practiced and that was my talk in Vancouver, where I made a strong case that if anything, it's more relevant in low and middle income countries. So for the purpose of this presentation, I'll talk about type 2 diabetes. I'm not going to talk about type 1 diabetes or other thing, but just type 2 diabetes. And then I'll talk about 2 conditions where precision diabetes already come to the clinic, and that's monogenic diabetes. And again, I'm just going to talk about 2 of those forms, MODY and maturity onset diabetes young, and neonatal diabetes, although we have many other subtypes. We have the mid type, and we have the genetic syndromes, and we have many others. I'm not going to go into those. Just a little bit about type 2 diabetes and then about MODY and neonatal diabetes. So type 2 diabetes, we all know, like that picture I showed you in the beginning, that one size doesn't fit all. All of us know that type 2 diabetes is not one disease. In fact, we have in India, and I'll probably show you a bit of it, we have people who have a BMI of 18 and they have type 2 diabetes. Well, you may say, well, that's not type 2 diabetes, it's type 1. It's not, because and all antibodies are negative. They have some C-peptide. They respond to oral drugs. They have a family history of diabetes. They have all the features of type 2 diabetes, but the BMI is 18. And then we have people with BMI of 50 coming in the other end of the scale. And so obviously you can't put everybody into one basket and say, this is type 2 diabetes, treat it with, that's what, in fact, the ADA and EASD did just 5 years ago. Start with metformin. I don't know if they remember those guidelines. Start with metformin. And next line, they had like 6 drugs. Sulfonylurea, TZDs, GLPs, DPPs, insulin, everything, and said, you choose, whichever you want, you choose, okay? Now, thankfully, next round of the ADA, EASD, they've said, no. If you're obese, you use this. If you're thin, you use this. If you want no hypoglycemia, you use this. So already precision diabetes has started coming. But this paper was a landmark paper by Emma Alquist and Leaf Group and colleagues. I'm sure all of you know that, because for the first time, they divided type 2 diabetes into different subgroups. And the 5 subgroups, as you all know, the first one, really we can ignore that, because that's not really type 2 diabetes, severe autoimmune diabetes. It's a form of type 1. You can call it LADA, latent autoimmune diabetes of adults. You can call it autoimmune diabetes. That behaves more like type 1. They're thin, they're ketotic, they have no C-peptide, the GAD antibodies are positive, except that it occurs in adults. There's nothing to distinguish them from type 1. So I would say it's just a variant of type 1. But the other 4 were of interest because they're really type 2. So we know that in type 2 diabetes, you have 2 main defects. One is insulin secretory defect and the other is insulin resistance. And always the chicken or egg story, we have always debated which came first, which is more important, and the debate has never been answered. Probably both are important. But if you divide them based on the phenotype, then you have one which has insulin deficiency as the main characteristic, and that was labeled as SID, severe insulin deficient diabetes. And these people tend to be younger, thinner, they have more of insulin deficiency, and they are not SAID or autoimmune because their GAD is negative, and they respond to some kind of oral drug. So that's the severe insulin deficient variety. The exact opposite of that is a severe insulin resistant diabetes. Obese people, high BMI, they have signs of insulin resistance, they have metabolic syndrome and all the features, and they call it as SIRD or severe insulin resistant diabetes. The third one is something which we don't see much in India. They call it as mild obesity-related diabetes, but no insulin resistance. So they have no acanthosis nigricans, they don't have other features of insulin, they don't have metabolic syndrome. But we look at the BMI, it's high, and therefore, and they're milder diabetes. So they called it as MOD. And the last one is easy, age-related, mild age-related diabetes, and their age of the mean age of the MARD was 66 years. We don't even get people, our lifespan in India is 69 years, and in men, and 70 in women. So we don't have too many people with onset above 65, 68. So when this paper was published, it created a lot of interest. And one of the things we first asked was, can this be applied to Indians? You may say, is this Me Too research? Oh, they did it, we have to do it. It's not so, because if you look at the type 2 diabetes in South Asians, and I'm sure you have the same phenotype here, those of you who have treated South Asians, I can list at least 13 differences from type 2 diabetes in white European population and South Asians. Now, and the South Asians themselves behave in a similar way, but they're different from the East Asians. So you go to China, Korea, Japan, they're different. But if you look at India, Pakistan, Sri Lanka, Maldives, Malay, Bhutan, and so on, they behave in Bangladesh, they all behave in a similar way. And enough studies from UK and from Canada and so on, which have shown that. So at least 2 or 3 of them, if I can list. First is lower age at onset of type 2 diabetes. We've known this for years, that whatever age you get type 2 diabetes here, clearly 10, 15, even 20 years earlier, we get the same disease. Second is a lower threshold for BMI, which means that if you plot with BMI and say, where does it take off the curve? You'll find the Western population somewhere around 25, 30, that's where it takes off. For us, it takes off at 18, 20, it's already taking off. By 23, it's already gone very high. So clearly a shift to the left as far as BMI is concerned. Third is insulin resistance. That is one of the first papers while working in the UK as a Wellcome Trust Fellow, 1986, that one, the diabetology paper. We showed that if you match the white person and the South Asian for BMI and match them for waist, match them for age, the Indians had higher insulin levels compared to, that was not known at the time, so well known now, but that was the first paper. And then we did clamp studies and proved that they were more insulin resistant. But what we didn't know at that time, and we found out much later, is that the bigger problem is the rapid decline in beta cell function. For some reason, we are losing beta cell function very fast. We still don't know why. Is it genetic? Is it all the rice that we eat? And yesterday, my whole talk at the other institute, Vasanti's Malik's department, was on diet. The whole talk was on diet and rice, and because we had Dr. David Jenkins there, and that's their interest. I'm not going to that now. But we do lose beta cell function, which means that we progress from pre-diabetes to diabetes much faster than many other races, except the Pima Indians. In fact, we looked at all the translation, the Pima Indian, but the Pima Indians have a BMI 5-fold, 5 BMI higher, 5 points higher. Our mean BMI is 25. Their main BMI is 32 or 33 or something. So at that BMI, they progress faster. If you just do a simple correction for BMI, we are the fastest progressors, okay? But the most interesting of all, and the reason I'm saying it is because we had to modify what Leaf Group and others had done. The most characteristic feature of the South Asian is the low HDL. We have the lowest HDL concentration in the whole world. No other ethnic group, Chinese, Japanese, you can take any other group, they don't have such low HDL. If you ask me why, we haven't been able to, we've been looking so many genetic studies we have done, and it's a characteristic. We really don't know. Similarly, we have this low vitamin D. Almost everybody in India has low vitamin D. If you ask me why, with sunlight and why you're getting that, you have no idea, but it's there. Low vitamin B12 in vegetarians is also very well known. So there are many, many such characteristics. The HDL and the increased triglyceride was particularly important because we had to put that into our model to get our types of the types of diabetes right. Until then, it wasn't fitting in. We used all the Swedish criteria and it just was going all over the place. We are not able to. The moment we put this in, everything fell into place. So this was a collaborative study with the University of Dundee, funded by the NIHR. It's called as INSPIRED. INSPIRED stands for India-Scotland Partnership for Precision Medicine. And it was published in BMJ Open Diabetes. So what we did in this paper was we first tried to exactly replicate, and it's there in the paper, what happens if you use the very criteria that you used. Complete nonsense. We're not getting anything. And then we said, okay, we give up on this. After several iterations, we said, now we'll use our own clinical criteria. The moment they had not used lipids, now I find increasingly lipids are being used for classification. Now I found that in Vancouver. So the moment we added HDL and triglycerides, everything came out and we had 4 types. Now, the first type, SID, and the last, MARD, looks as if it's the same as in Sweden, but actually it's not. Because the mean BMI, of course, it was lowest in Scotland and their group, in Sweden and their group as well. But our mean BMI is far, far lower than theirs. There's no comparison at all. Similarly, our MARD, mild age-related diabetes, we call it as age-related. The mean age is 53 years, which is the mean age for all the groups in Sweden. And theirs was 65 plus. So they're completely different groups. And then the IROD, the insulin resistant, why we didn't call it as SIRD and call it as IROD is because they didn't have dyslipidemia, which the SIRD group there had. Okay, they didn't have. But most interesting was the third category, which we called as combined insulin resistant and deficient diabetes. So they had the features of both SID as well as IROD combined in them. To us, although it's only 12% of all the patients we saw, this was the most characteristic. Because while all had low HDL, these guys had very, very low HDL, much, much lower than the other 3 groups. And the triglyceride level of this group was double that of any of the other 3 groups, literally double. So they had classical dyslipidemia, and they had features of both insulin resistance and insulin deficiency. And it was a novel cluster. We were the first to describe it. It's now been reproduced in others. So before that, what's the clinical relevance of the clustering? Here, we found very similar to what Leaf Group had described. If you have the SID variety, the thin insulin deficient variety, you are more prone to retinopathy. Whereas if you had insulin resistance, then you're more prone to kidney disease. And that was similar to what the Swedish group had shown. So what about the group in between, the CARDD group, who have both? Not surprisingly, they were more prone to both retinopathy and nephropathy. So that was another characteristic of this group. The other thing was with regards to treatment. Now, before you start thinking of type 2 diabetes into different buckets and so on, we treat everyone the same way. We start with metformin, then add something else. And we find one group responds well, another group doesn't respond well. And we're always foxed by that. Why is it some are responding and, oh, maybe it's pharmacogenomics, maybe it's something, maybe it is. We know the SLC gene, determines whether you have side effects with metformin and your response to metformin. But here, what is shown, the 4 groups that you see here, is that if you look at the top one, the green line, that is the MARD group. And they respond best. They're mild, they get it after 50 years, just give them metformin or any drug, and they respond well. At the bottom, the blue one is the SID group. Now, those people who have very low insulin deficiency, they have severe insulin deficiency, you're treating with metformin, and they're not responding. We're looking at a retrospective study, by the way. It's not a prospective study. So they don't respond well, and they probably need a secretagogue, or they need insulin or something else. The one hugging that group, the red one, is the SERD group because they have insulin deficiency, so they are not responding well. So at least as far as response to treatment is concerned, the groups are behaving differently. So it makes sense when a patient walks in to say, thin guy, maybe is SID group, obese guy, maybe is IROD. Then an elderly gentleman comes around, MARD probably. So even as you walk in through the door, you make the diagnosis. You really don't need, of course, the SID one alone, but then you have triglycerides, which are sky high, and HDL, which is so low that you can pick that up easily, okay? So I'm happy that the clustering then was replicated in South Asians in the UK by Sarah Finer's group, and they showed that the SERD variety is there in the Pakistanis and the Bangladeshi. So it seems to be a South Asian one. Subsequently, a review article was published where some Chinese groups have also described the SERD variety. So there are Asian groups where the SERD variety is present. Now, Andrew Hattersley and John Dennis visited us a couple of months ago. And John Dennis is one who says you really don't need all this clustering, okay? Use simple clinical, don't try to bucket people, because even within that bucket, there's so much of variation. That's the problem with type 2 diabetes. So he says, you don't need all this. And this is a nice paper which he showed that you can develop treatment selection algorithms just using clinical parameters, BMI, age, A1C, family history. From those, you can work out. And what he did is actually quite path-breaking work. So he looked at only these 5 parameters: HbA1c, BMI, current age, eGFR, and the ALT, the liver function. So with that, he was able to predict who will respond to a DPP4 inhibitor and who will respond to an SGLT2 with very good precision. He then went back and applied this in various trials, which had already been done, where they had the answers. And then he used his model to see whether he was able to predict, and he was able to predict it very well. So he says, don't bother about clustering. You just do this. And they came to kind of brainwash us to stop thinking about clustering and to start using this. It makes sense. Now we're going to apply this in our model and see whether in a South Asian, they don't have South Asian data. So they wanted to know whether they're able to use this model in South Asian. So even this is part of precision medicine, no doubt. Whether you cluster them and think of them as a group, or at an individual level, you're going to say who will respond and who will not respond. It makes sense. I'm not going to go into that, but a lot of it is there in his paper. For example, he takes 2 individuals, Claire and Anthony, and then he says, Claire has one type of diabetes, and Anthony has another type of diabetes, and how do you expect them to respond? And he's able to say SGLT2 will respond to somebody. He's even able to say who will get side effects and who is likely to drop out. So things are getting better and better as you start applying this mathematical modeling. He's a statistician. He's not a clinician. He's a mathematician. So with that, he's able to predict much better wired brain there than we poor physicians who know mathematics at all. So I think we need to collaborate with these people. Now let me move on to monogenic diabetes. Now, maturity onset diabetes of the young, first described by Tattersall and Fayance in 1975 in their classical paper, had only clinical criteria. So very soon after that, when I finished my post-graduation, I published a series of cases on MODY, so-called MODY, but there's nothing but type 2 diabetes, only a few of them, because there's no genetic test to prove that. And it's only in 1992 that the first MODY gene was discovered. And then after that, of course, we got these 14 different types, of which 3 have been dropped. The MODY 7, the MODY 9, and the MODY 11 are no longer MODY. So we cannot even call them as MODY. They've been dropped completely. The rest of them are, but some of them are very rare. And the most common ones, are the first 3. MODY 1 or HNF4 alpha, MODY 2, which is GCK MODY, and MODY 3 is HNF1 alpha. And MODY 1 and 3 respond to sulfonylureas. GCK doesn't need any treatment unless you go into pregnancy. And some of them, recently we have found that MODY 12, ABCC8, behaves exactly like MODY 1 and MODY 3. And we have a large series now coming up. We publish on each of these, MODY 3 separately, MODY 1 separately, MODY 2 separately, MODY 5 separately. And then we found a new MODY type, which we described in a BMC medical genetics paper. But then we started narrowing down and said, why should you even diagnose MODY if they are not, for example, MODY10, the insulin gene mutation, it's like a type 1. They don't respond to sulfonylurea. So what's the point in doing genetic testing to say you continue with your insulin? So only if you're going to make a change, is it worth spending money? So Aarti Ramasamy, who's my PhD student, she just got a PhD and she's completed. So she worked on this, and we first of all narrowed it down and said, let's talk about the common MODY and the less common MODY. And the three which are circled, MODY 3, 1, and 12, are the only ones of interest to us. Those are the ones which respond. Of course, MODY 5 is of interest because they have also congenital abnormalities of the kidney or the uterus and pancreas, but they don't respond to sulfonylureas, by the way. They need insulin. So our main interest is 3, 1, and 12. So the next question is, okay, so these are called as actionable MODY. But when you have type 2 diabetes presenting at a young age in our population, even without insulin resistance, no acanthosis nigricans, and then you got type 1, when you're sitting in a clinic, who should we send for genetic testing, given that there is a cost attached to that? So that's a kind of $1 million question. It's not really been answered by anybody, how to pick that up. Because the MODY, call it MODY Exeter, they have this, calculator. So the MODY risk calculator. So that doesn't work in South Asians. And they have shown that, very poor pickup. So they are also struggling to find out. That's why the collaboration with Andrew Hattersley. But what we did was we said, let's do reverse, let's go in the reverse direction. Let's take MODYs who are definitely proven. And the criteria for diagnosing MODY has got stricter and stricter. So now we have ACMG criteria, and you have NOMAD criteria, and you have many, many criteria. So many of the old MODYs which are described are no longer MODY. You have to have very, very strict criteria now. So using the strict criteria, which is now internationally accepted, we said, let's take out the MODYs and then see what is their highest BMI, lowest BMI, what is their C-peptide, what is this, what is it, and then compare them with type 1 and type 2. And can we then separate them out and say, if you have these characteristics, then you refer them for genetic testing. And so that's what is shown here, the clinical features of these three groups. And then we drew density plots and said, okay, does age at onset help to answer? Now, type 2, you can see the green dotted one goes off. But a lot of them on the young age as well. We have type 2 diabetes age of 10, 12. So that doesn't help. Then we looked at BMI. Well, again, there is an overlap. Then we looked at A1C, didn't help. HDL cholesterol, of course, they tend to be lower in those with type 2 and normal in, but then type 1 and MODY, they overlap. Then we came to C-peptide. C-peptide fasting was also useful because you can see that straight peak which goes up, that's type 1. So they have virtually no C-peptide. So you can separate them out. MODYs have some and the type 2s. But when we looked at the stimulated C-peptide, which we use a very simple test, we've been using it for the last 30 years. We give them a breakfast, standard breakfast, 90-minute, we anyway do the postprandial sugars, glucoses on everyone, we do a C-peptide. So we have got hundreds of thousands of C-peptide in our electronic register because it's like a routine test for us now. So we said, okay, so that seems to separate out quite well the three groups. Then we did the ROCs, and then we did the area under the curve. And it turned out that to separate, particularly from type 1, if you want to separate, the sensitivity of a C-peptide, cut point of 2.1 nanogram per mil, was 100% specificity and 96% sensitivity. So that was great. We said, okay, so those who have lower than that, don't test because they're going to be, you may miss one MODY, but it doesn't matter. It's not cost effective. Similarly, we have in the paper, we have a similar one with type 2. It's not so great, but still about 90%. 95% sensitivity and specificity, even for type 2. So now we know whom to screen for MODY quite cost effectively. So with that, let me now pass on to the even more interesting type of diabetes, which is neonatal diabetes. As you know, neonatal diabetes is diagnosed in the first 6 months of life. After that, it can, so type 1 diabetes before 6 months of age is extremely rare, but you can't rule it out because we have seen even GAD positive child 4 months old. So it can happen. It's very rare, but it can happen. You cannot rule it out. So there are two types, basically, the transient variety, which occurs before the first 6 months, but it disappears before the first birthday. They don't get referred to us because self-limiting, it goes away. During that time, they treat with insulin anyway, and then the child spontaneously remits. Sometimes it comes back in adolescence or young adults. But the other one, permanent neonatal diabetes, it occurs within the first 6 months of life. And if you don't diagnose it, they are treating it with lifelong insulin therapy. Whereas those children with PNDM, if you're able to do genetic testing, there's a good chance that you can take them off insulin. So nothing like a case study to illustrate this. This is one of my first children who came all the way from Kolkata, the city of Kolkata, which is more than 1,000 miles away from Chennai. So this child, we had already set up our genetics lab, and physicians all over the country are beginning to know that we are doing genetic testing. So this child was diagnosed, and just because she was diagnosed at the age of 3 months, a physician mentioned to her that, there is a center in Chennai which may be able to do a genetic test. And if so, you can go off insulin. She was already on 4 injections a day, 14 units of insulin, which means her, at that body weight, she was receiving 3.5 units per kilogram body weight. And her blood sugars are not coming down. Very, very high. I know you use in millimoles, we use milligrams. So, but before even the results came in, it used to take 3 weeks. It still takes about 3 weeks for us to get the results. The parents couldn't wait, so they brought the child over to our center. And coincidentally, just when the child arrived, we got the results of the test, just when she arrived at our center. And of course, we had done the genetics. And lo and behold, she had a KCNJ11 mutation. Now, KCNJ11 and ABCC8, or the sulfonylurea receptor, these are the two which classically respond, almost always, almost 100%, they respond to sulfonylurea agents, which means they don't need insulin. Unfortunately, only 50% of those with permanent neonatal diabetes have these two mutations. There are others, like the insulin gene mutation can occur, the GATA mutation can occur. They don't respond to sulfonylurea. And about a quarter or a third of them, we can't even find the mutation. Nor can Andrew Hattersley and etc. So we're trying to now do exome sequencing and whole genome sequencing to find out what they have. So obviously they have a genetic defect, but we're not able to find it. But this one, she's lucky because this one responds to sulfonylurea. So what we did was we changed so glibentelamide is the cheapest sulfonylurea you can get in India. Old one, rarely used now, but most of the MODI and neonatal studies have been done on glibentelamide. Glyburide, you call it in the US. Of course, glycoside also works. We have glycoside also, but we had started this child on glibentelamide. And you can see the response. Now that's how the green one is how the sulfonylurea dose was built up. The red one is the insulin dose. So she came taking a lot of insulin doses on the other side. So 12, 14 units. The blood sugars are on the left side. And the insulin, as the sulfonylurea dose was stepped up, insulin dose was brought down. Look at her blood sugars shown in blue. Look at the column where before you started the sulfonylurea and you just had the insulin, sugar is very high, not responding. As the sulfonylurea dose went up, the glucose levels came down. And with insulin completely gone, she responded beautifully, okay? Now, this, of course, by day 5, we completely stopped her insulin. This, of course, makes big news. And the reason it had to make big news was because nobody knew about this condition. Pediatricians, neonatologists, physicians, endocrinologists, nobody thinks of small child, type 1, start insulin. And if it doesn't respond, increase the dose of insulin. Now, this was a kind of a revelation because here was this baby who came and she treated and so it became very big news. Slowly, word started spreading all over India. That's how she was 9 years ago, and that's how I looked 9 years ago with the baby and her mother, and her uncle had come at that time. That's my son-in-law, Dr. Ranjit, in the picture. And then, very, very pleasantly surprised when she came back in December 2023, just 2 months ago. The baby is now 9 years old. And what's fabulous and what is so, so rewarding is that from the day she left the hospital until today, she's not taken a single shot of insulin, not one. And she doesn't even do home glucose monitoring because the sugars are so stable. She doesn't do pricking and going to the thing. Occasionally, she goes to a lab in Kolkata. We have a center there, and she does her A1C. Her A1Cs are 5.8, 5.9, for the last 9 years. It's a complete miracle as far as, to me, this is the greatest miracle in diabetology. Somebody comes with insulin, take them off the child, never needing insulin again, sugars absolutely controlled, no hypoglycemia, and A1C of 5.8, 5.9. I mean, you can't think of a better situation than this. So what benefit did this is the case that I presented at Vancouver, because the general feeling was, I won't say which industry, but they had approached an industry asking for support for doing genome precision medicine in developing countries. And they said, don't waste time. They've not even treated their malaria. They haven't even given insulin to the poor people. So why are you even talking about us? It makes no sense. And so the project was shot down and is not funded. So I said, okay, look at Ivana Das. If genetic testing was not done, she would have now taken 13,140 insulin injections over 9 years. Imagine that small girl taking this many insulin shots. The cost of insulin is very high in India compared to glebentamide, which is like some 2 pence or something here, and or 2 cents or whatever you call it, and $2,000 she would have spent on that. Cost of glucose monitoring, add another $1,000. So total cost should have spent $3,000. Now, that may not seem very big by Canadian standards, but if you look at her father and what he was earning, mother doesn't work. Father, his monthly income is $240. So with $240, if he had spent $3,000 just for the insulin, and she has to pay from a pocket, she might go to a government institution in Kolkata. She may get her insulin sporadically for the monitoring. She may not get at all. And she may not get the same insulin every time. And so she would have had to pay out of pocket, okay? Now, look at the other side. Thanks to genetic testing, insulin stopped, 13,000 injections avoided. The cost of neonatal diabetes testing, this is the other point which I made at Vancouver. When you say that in developing countries, low and middle income countries, they can't do anything, we do our genetic testing for $24. I challenge you that it cannot be done, either in Canada or UK or US for that cost. You cannot beat us in that because it is so cheap. We keep the labor so cheap that we are able to get it at that cost. And of course, we didn't charge her at all because she couldn't pay for that. So we paid. So we've created a fund now, personal donations, other patients donating. So you've got a fund now to take care of neonatal diabetes and Modigen. So they don't have to pay at all. From anywhere in India, they can send us the samples. Cost of sulfonylurea over the 9 years was $80. Instead of the $3,110 she has spent, she has totally spent $80. Less than $10 a year is the cost that they spent, okay? And that's the amount that she saved. If genetic testing was not done, if she was not referred to a center, she would have still been on insulin. And this is my fear. That's how many Ivana Dases are there in the world, in India, for example. Let me not worry about the world. First, think about my own country. And how do I get to them? So we started what's called as a monogenic diabetes registry. And I said, let's register all these people. Thankfully, the word has spread. And today, if in any medical college in India, any pediatrician in India who knows about this, they just give us a ring or send us an email and say, we got a child. Can we send the blood? Even the child doesn't have to come. We need only the blood. Say, okay, send the blood. And we tell them how to do it. They have to get the informed consents and other things sorted out. That's there in the registry. And then they send it to us. Over the last few years, over 2,000 cases we have done. We're doing it completely free of cost. Being a private center, our investors and our shareholders are always asking, what's the return on investment? Is it the return on investment is the happiness we get? There's nothing more we get out of this, purely altruistic. We have no other agenda here. And you can see 379 NDMs have benefited. A few had the other types where they didn't respond, but the majority did. Now, the other one next to that, the NDM syndromes, these are children who are diagnosed with type 1 diabetes. But if you suspect that it's just not type 1 and you do a genetic test, it may turn out to be Walcott-Rollison syndrome. Now, if they have Walcott-Rollison syndrome, that child may not see his or her 18th birthday. Before that, they die of either liver disease or kidney disease or both. So it's useful for the parents to know, because they're planning to have another child. They can get, because this child is not going to live. We don't have a cure for Walcott-Rollison syndrome. There are others down the line. You look at SLC, that's thiamine deficient megaloblastic anemia. If you give thiamine, which is one of the cheapest drugs in India, the anemia goes away and the diabetes goes away. They don't need any treatment. You just give them thiamine, B1, and it's gone. Their diabetes is gone and the anemia is gone. Two birds with one stone. If you don't do genetic testing, you're not going to do that. You're still going to give them insulin and keep treating. So I think precision diabetes is not something fancy. It is something which is game-changing. It is something which you all have to think about. Only thing is, the challenge is, how do you identify these people? So as a clinician, you must have, your radar must be very good, your antenna must be very good, because you must pick up, otherwise it's not cost effective. You cannot just keep screening everyone for genetic testing. MODY, of course, we talked about. The opposite condition, which I didn't even mention, opposite of NDM, almost equal numbers you can see. Congenital hypoglycemia of infancy, hyperinsulinemia. Exact opposite. They get it before 6 months of age, even much earlier, 1 month, 2 weeks, and they're presenting with hypoglycemia and hypoglycemia and hypoglycemia. Now, whatever you do, they keep getting this hypoglycemia. Earlier, they used to go for subtotal pancreatectomy. Before the age of 1 month or 2 months, they get wheeled in, and then most of their pancreas is removed, 80%. And only then the child can live. Today, thanks to genetic testing, we can find out which genetic mutation we have. And since we have a large series now, we can say that this child will respond to diazoxide. And then we give diazoxide. There are a few who will respond to octreotide. And then there's a very small number, less than 5%, who won't respond to anything, and they need subtotal pancreatectomy. So we are saving a pancreatectomy on this newborn child. So precision medicine is completely game-changing. And it has also become a reality because it is applied to all forms of diabetes. Even in type 1, we are beginning to see some are GAD positive, some are negative, some have better C-peptide preserved, some have less C-peptide preserved, but the treatment is still insulin. So we don't bother about type 1. Type 2, the clusters we believe the clusters are very important. I didn't show you for lack of time, but I showed it in Vancouver. We have a program, we have a software program called Diana. And so Diana program, you just put in the height, weight, family history, and so on, and it'll immediately tell you, the program in a second, it'll tell you, this is probably SID variety. Think of a sulfonylurea or a DPP4, and so on. It tells you that. We are now doing a trial where we are, first of all the other studies have been retrospective. Now we're doing it prospectively. We select out the SID, we select out the SERD and the CARDD and the IROD. And then one group within each, we treat in a conventional way. Metformin, this. The other one, according to pathophysiology. So it's called as an aggregate study. The recruitment is already getting over. And this will be one of the first translational studies based on precision medicine, classification of type 2 diabetes. So we'll be able to finally show whether it's worth doing this. Suppose it finally turns out to be the same, then it's a waste of time. You don't have to do that. And we don't know the results. It's still unblinded, but it's still blinded, so we don't know. But that's a trial which hopefully next time I can share. Monogenic diabetes is a classical poster child of precision diabetes. And of that, I think it is the neonatal diabetes and the CHI, which have the maximum use of precision diabetes. And naturally, when you make a precision diagnosis, it offers precision treatment and therefore improves the quality of life. And I'd like to end by thanking my colleagues. The lady in the middle wearing the black sari is Dr. Radha Venkateshan. She's been with us for almost a quarter of a century now. She set up the Genomics department. The one next to her in the yellow, she's Bodhini, who's the lead author in the precision diabetes prevention study, and many others. Kanti next to her is the one who does the Modi and the neonatal diabetes work, and a whole host of people who have been working in this. And I'd like to thank them all. And I hope I've convinced you that there's no one-size-fits-all store where you can just go and buy whatever you want. And you have to start thinking of different scenarios when you treat people. And with that, I'd like to thank you for your patient hearing.
Thank you so much, Dr. Mohan. That was such an inspiring and thought-provoking talk. I want everybody to join me in thanking Dr. Mohan. I just want to see if we want to end the slideshow. We can see if there are any questions in the chat. Not yet. Okay, so I will ask, as people are thinking about questions, if you just want to raise your hand on Zoom, and in the meantime, I'll ask if people have questions in the audience.
Sure.
Beju.
Thank you for that talk. That was excellent. I wanted to ask about your thoughts for this whole, you mentioned, having your antennae up for detecting these. And I think, the cases like Ivana, in pediatric endocrinology, maybe it's more obvious or it's easier, but as adult endocrinologists, the yield is going to be that much lower, right? So what are the things that, in your perspective, should be for your antennae to really set them off?
So if anything, for example, type 1, okay? So you're treating somebody as type 1. And in type 1, we know that a simple thing, if you're doing CGM, you will find the glucose levels going like that. That's how type 1 behaves. If you find someone whom you're treating and the A1Cs are not all that high, A1C will go to 12 and 14 and in type 1s, but you have never seen an A1C above 8, 8.5. And then you do the glucose monitoring, it's not most likely it's not type 1, okay? And then you look for a family history and you find, hey, father's diabetes. How many of our type 1s have a parent with diabetes? It's not common. You find the parent also has, some grandparent had, and somebody. Now you're antenatal. You looked at the antibodies negative. Go for it. Go for the Modi genetic screening. Maybe you can stop the insulin and change the sulfonylurea. If you find any other extra pancreatic features, you find that you've got a child whom you're treating, but the liver function is abnormal. Why would liver function be abnormal in a type 1 who's 12 years old? So they probably got Walcott-Rollison syndrome. And then you find the creatinine slowly going up and so on. You can't get renal failure at the age of 12 with type 1. So these kind of things, you do an ultrasound and then you find there's an absent kidney or something, it's modified. So like this, you build up your clinical thing and say, this is unusual. This is not following the usual pattern. Only those, if you focus on, it's fine. If you're convinced somebody had ketoacidosis, C-peptide is negative, GAD is positive, it's type 1. Why do you even bother to look further? There's no point in wasting time. Below 6 months, everybody, of course, everybody has to go for screening. So I think if we have this kind of a thing, even if you're able to help only, see, after all these years, only 2,000 people have been able to help. For 2,000 people, that's a game changer. Somebody has to do it. And like Ivana Das, see, we have got 400 cases referred. Assuming before that they were all sent to Exeter or somewhere, and another 100 or 200. I presume there should be at least 10,000 children in India with 1.44 billion, and the number of newborns in India, even if you take it as 1 in 400,000 or 200,000, it's still very high. So where are they going? They're probably dying because they must be going into a coma at the age of 2 weeks or 1 month or 2 months. They may not even do a glucose level. They probably do a lumbar puncture to look for meningitis or something, encephalitis or something. And they may not do a glucose level at all. So I'm sure there are children dying. So can we pick those up? Can we spread the word around and then pick up those cases? Then coming to type 2, we just have to keep somebody very obese walks in. We have got drugs for weight reduction. So we'll probably prefer those. Then a thin guy who comes in, you ask me that question, will you use a GLP-1? I can probably use it, but it's probably not the best drug for that person. For the cost given, the chances that an occasional patient there may respond, we don't want them to further lose weight. And so I think consciously or subconsciously, we're already practicing precision medicine. But when you write it down like this, it trains our brain a little differently. I always kind of boast to my juniors and colleagues to whom you can boast that I really don't need computers. I can tell you who will have, I may not know Modi 1 or Modi 3, but I can tell you it's probably a Modi or of course, neonatal diabetes is even easier. So I think instead of treating everyone in the same way, start thinking that people are different and which of these will they fit in. I think we begin to do that. I think that's a good start.
Thank you. We have someone in the chat. Let me see. Okay. Oh, sorry, Glenn Thibault left. Okay, thank you, Glenn. Okay, so any other questions? Go ahead, Calvin.
Thank you, Dr. Mohan. I think that was a really excellent talk. And when I did my PhD looking at diabetes in South Asians and in Chinese populations, anytime I wanted to know what the best practices were in India, I just read your papers and everything is there. So it's really excellent. My question is about precision diabetes and the pharmacologic management of what we call type 2 diabetes. So, based on the work from John Dennis that you showed, there may be slight differences, in some cases, bigger differences in the way that, certain people respond to DPP-4 inhibitors or other classes of drugs. And, if we're thinking about the most difficult cases that we have where, we want to know which treatment might work best, let's say their A1Cs are quite elevated, they're probably going to need more than one agent anyway, right? So let's say they might benefit a little bit more, a little bit less from each one, but you're going to use 4 different non-insulin agents anyway. Does it really matter that we, know which one they might respond slightly better to, or should we focus more on multiple agents working together?
Great point.
Do you want to quickly repeat what he asked?
Okay. So the question is that, when you have A1Cs which are very high, you might need multiple classes of oral anti-diabetic drugs used. So what does it matter which you use first, or should you still have a precision medicine approach when they're definitely going to need more than one drug or more than 2 or 3 drugs? That's a very valid question. And in somebody who has very high A1Cs, for example, if somebody walks into my clinic and has an A1C about 10 or 12, I would give them insulin to start with, because we have to correct the glucotoxicity if anything else has to work, and dramatic. The results are really dramatic. If you give them insulin, one basal insulin for 1 month, it completely changes the natural history. The C-peptides improve and everything improves. So in those if somebody comes with a DKA, you're not bothered as type 1 or type 2, you'll treat the DKA first and then bother about, but even there it makes a difference. See, the other day, I had a 14-year-old, is a son of a colleague of mine, who came in with more than, close to 1,000 milligram blood glucose levels. That's what, 40, 50, something millimoles. And he was admitted in the ICU, and my junior colleagues who had seen him the previous evening came in the night, and so it was handled by my juniors. And they started him on insulin, done all the right things. But the moment I went and saw him, I said, this is not type 1. This is type 2. He had severe acanthosis nigricans, which they had missed completely. He was on the obese side. He has complete, acanthosis nigricans. So I immediately said, there's something missing here. Why would somebody with type 2 diabetes develop ketosis? And quite often, things come from unexpected sources. So there's a lady standing next to him, and I said, who is this? They said, it's his aunt. So I said, where's his mother? Oh, mother has not come. I said, that's the problem. There's something wrong here, Then I found that his father and mother were about to get divorced. And that stress has brought on the type 2 diabetes. the clue came from the acanthosis nigricans. Okay, at that particular time, treating him, you would treat like a type 1. But in my mind, I already knew that this is not type 1 because ultimately they don't need insulin. True enough, 3 weeks later, he was off insulin and now he's on oral drugs and he's beautifully controlled. And the stress, we'd give him counseling sessions and so on. So the approach would be very different. In an acute situation, you would always treat like that. And we are talking, most of this question was asked to John Dennis at Vancouver. Does your rules apply for somebody who had at diagnosis and somebody after 5 years, 10 years, 15 years, 20 years? After 15, 20 years, everybody needs 3-4 drugs and they need insulin, and really doesn't matter. We are talking about precision diagnosis and treatment of type 2 diabetes at the time of diagnosis. Somebody is walking in, which drug will you use first? That is where it makes a difference. Once you've lost all your beta cell function and your A1Cs have gone up and 2 drugs have failed and 3 drugs have failed, their precision diabetes has lost its value at that time. You somehow get your parameters under control. We call it as ABC, A1C, blood pressure and cholesterol. You get these 3 under control and that by hook or by crook, you bring it down. And so I think it depends on what stage of the disease. Now, if costs vary a lot, for example, the GLP-1s in our country are still not off patent. Although the first one is liraglutide is now becoming off patent and the 70% reduction in the cost. But if you take SGLT2s, DAPA is already off patent. So we can get it for the cost of sulfonylurea now, okay? So before that, before this thing came, we'll think twice. Does the patient really need an SGLT2 or could we get by with sulfonylurea or metformin? So where costs matter, again, trying to get a handle on which drug will work better makes absolute sense. I think we have to use these. They are useful tools, but it's not the end of precision medicine. As we go along, I think it'll evolve. And we are still in very early stages. The monogenic diabetes is an extreme. You can easily, pick up something and then start treating in that manner. And the fact that after 9 years, she still has not needed insulin means that it's long lasting. It's not just for 2-3 years. And so for a long time, it works. So I think we have to use our clinical judgment. Ultimately, it's our own clinical judgment and the patient's preference also has to be taken to.
I see we've gone over time and we have one question in the chat if people want to stay. Oh, yes, Varsha. Thank you, Dr. Mohan, for the research you shared and even more importantly, the work you do in treating Indians and for educating the professionals across the globe on culture responsive scientific treatment. Varsha is one of our advisory board members who unfortunately, she had to drop off. Yes, thank you very much. So I'm sure people may have other questions, but in the interest of time, I am going to close this session and please join me in thanking Dr. Mohan for such a wonderful talk. We're really appreciative of his time and for coming to visit us. Thank you so much, Dr.